Thank you for joining us today for a My Varian webinar event. We are delighted to have Jonathan Stenbeck from Prisma Health and our 2018 Physicist Plan Challenge winner with us to share planning tips for difficult head and neck cases using Eclipse. Before I turn it over to Jonathan, I'll give you a moment to review the Varian safety slide. And as a reminder, all products and services are not available in all markets. And Jonathan, you are good to go.
All right, great. Well, thank you, Karen and Drew, and all the other people at Varian for helping organize this. I'm going to be talking about head and neck planning. I put tips, tricks, and thoughts on there. Just couldn't really come up with a better title, and figured content would be more important than the title. So here's some disclosures, the slide that has to go there. And for background, I'm a physicist at Prisma Health in Greenville, South Carolina. Been here about 5 years. And in general, I try to learn and teach as much as possible. I think it's great to share anything we know with anyone who asks. And I really like to focus on treatment plan quality and techniques involved in that. And I think it's a really big focus in that should be in our department. And sorry, just getting lots of comments here. Okay. So yeah, I really like to focus on treatment plan quality, and I really like physics and dosimetry to both be involved in that. The objectives of this talk, I want to just provide some techniques and strategies to help a planner create a good head and neck photon plan in about 2 hours. So protons, completely different ball game that I know next to nothing about. But for photons, that's something I can talk about. So for a general plan, if you have about 30 minutes or so to contour normal structures, and I put a small coffee break, and then you spend about an hour planning. So that's in general 2 hours, but that does not take into account physician contour time, because that is a mystery. It could be anywhere from a very short period to days, and typically has a question mark next to it because you don't know when you're going to get them. And I'd really like to encourage this conversation in your department between physics and dosimetry. It's just, I don't know, it seems like the more you talk about it, you can refine things and just end up with better quality. And I really don't want treatment planning to become a black box. There's a lot of different products that are coming out that do really great things, but it's really good to know what those products are actually doing. And so I think the more techniques we know, sort of the better tool set we have. And like if you're cooking, you don't want to just know the recipe. You want to know what the ingredients are actually doing. So I'm just going to kind of dive into the content. I'm kind of giving this talk hoping that people have a pretty good concept of head and neck planning or just treatment planning in general and what an optimizer does. So head and neck treatments are normally thought of as harder cases, and for a variety of reasons. You have a high number of normal structures, so just lots of things to contour and keep up with. There's a complexity in PTV generation that you're not going to see if it's like a prostate patient. These PTVs are going to be different from patient to patient. There's typically different dose levels. And in addition to the PTVs, just the patients are going to look very different. Some patients are bigger, some are smaller, some have bent necks, and there's just a wide variety where pretty much every patient's going to be unique. It's hard to apply sort of the same solution to every case. And when you're optimizing, there's just a lot of different things to keep up with and evaluate. And then one of the most frustrating things is that the CT we take of these patients is rarely what the patient looks like all the way through treatment, especially once you get to week 4 and 5. You typically see weight loss and things like that. And so those are kind of some of the things that add to why we think of these as complex cases. So things we're going to go over is contouring, not contouring like the normal structures, but contouring that'll help in your optimization. So coming up with different planning PTVs and things like that that'll help move things along quicker. I'm going to go over geometry that we use. We use it in our clinic and have kind of adapted it, and then talk through some optimization techniques, a really quick explanation on evaluation for different things, go over a course of treatment. So for instance, when a patient does lose a lot of weight around week 4 or 5, like what do you do with that? Do you have to replan? Can you continue? How do you evaluate that? So sort of that decision-making process. And then I put complicated cases on there. just sort of like retreatment, things like that, when you have to make decisions that aren't really common. And so just to jump right in, optimization PTVs. So typically people use these in head and neck planning, and there's a lot of different ways to make them. And so one of the purposes of the optimization PTVs is you really want to minimize dose spillage outside of the higher dose PTVs. So I have a picture up here of kind of your standard head and neck, like a PTV 70, a PTV 63, and a PTV 56, let's just say. And I mean, the goal of the optimization PTVs is to keep those doses from spilling into the lower PTVs. And that becomes really important when you start getting into like the mid-60 gray, upper 60 gray doses, because that's where you can start to cause necrosis outside of. I mean, if that's in your PTV 70, that's great, because that's normally the bulky disease. But when you're off in soft tissue or it's spilling outside of a PTV, like you don't want a PTV 56 getting 65 gray. And so an optimization PTV can be made a lot of different ways. The way I like to do it is I tried to come up with a formula, because it seems like people like formulas. So mine are, I like to make them a little bit bigger than I've seen presented before. So some people will say like every 5 to 10% to do a millimeter. But I like to say about for each 1% in dose change to add a millimeter. And so for a lot of times you'll see about a 1 cm expansion of like a PTV 70, and then subtract your PTV 63, or subtract that from your PTV 63 to get an optimization PTV. So if we look at this equation here, I called it just a PTV 63 opti. And so you're going to take your whole PTV 63, and then from that you're going to subtract an expanded PTV 70. And to give some more just specific examples of what I would actually do on constraints, on that optimization PTV, now you can put a very tight dose constraint on there. So if you're only 1 or 2 millimeters away from a PTV 70, you're not going to be able to actually get the optimizer to account for like that lower dose, so like a 64.5 or 65 gray. So it's going to have some 70 gray right there because you're right next to a PTV 70. And so if you are doing a 1 or 2 millimeter PTV, like an optimization expansion there, you're going to kind of compromise your coverage some on your higher PTVs. So I'm hoping that makes sense. Again, please ask lots of questions here. That's kind of the goal of this talk, is to get people talking. One other thing when you have this bigger gap is you need to have a lower objective on the actual PTV 63. And so if you don't have that, you could get dose squeezing in between the two targets. And then on the actual PTV, you also need to have an upper objective that's approximately at what the higher dose PTV is. So I realize that's a lot of very technical talk right there, but I hope that's making sense. And again, ask questions, and I'll try to explain that a little more thorough if needed. And then over here, I just kind of pulled up a screenshot of what this would actually look like in an optimizer. So I'm trying to give some just very specific examples of what I would do on these to hopefully convey that. So let me pull up this laser pointer here and just kind of walk through this. And again, this might be something that you're very used to seeing, but if not, just humor me. So if you had 3 PTVs, one going to 70, one going to 63, one going to 56, you could have your PTV 70 where you just have sort of your typical coverage constraints, 100%, 0% dose, or volume at about a 2% hotspot. That's not always the most realistic dose values, but again, just for the sake of showing this here. And then for your PTV 63, you're going to have that PTV as well as a planning one. And so this green one here is the actual PTV. So like I said, you really need a lower constraint on that to make sure that you're going to have full coverage. Because if you just put a lower constraint on this planning PTV, you could have a fall off in dose between the two structures. And then on this PTV planning, you can put a very tight dose fall off on it. So what that does is when you're looking just at this structure, if you were to take a line and go through this profile here on the PTV 56, you'd have a very homogeneous dose distribution in here. You wouldn't find like a 60 gray or so floating down here in the bottom, which If you did a 1 or 2 millimeter PTV expansion, you don't have a good method to eliminate that dose unless you go in and you're actually contouring out voxels and saying don't put dose there. So in terms of making a quick plan, those PTVs work pretty well. So another topic here for optimization, removing skin from targets. This is something that, we typically do, and you just kind of hear the reason of, oh, optimizer doesn't do well on skin. But that's a very true statement that we need to be reminded of, because even if you subtract 2 or 3 millimeters from the skin in a PTV, you still might get something that looks great on paper. But when you actually go to treat the patient, you can have a very, very hot spot in there if the patient is not completely identical to the CT. So to sort of explain this a little more, I made a cylinder here and optimized it. So again, pull up laser pointer so if you guys can see this. So made a cylinder and just kind of made a little blob on it. This kind of seemed like a neck to me. So, and I made a PTV that was 2 millimeters away from the skin and optimized. And you get like a decent looking homogeneous plan. It's not ideal by any means because this is just for example. But what this is doing when it's actually optimizing this is you're not getting a lot of beams coming straight in through this PTV when you're optimizing, because if you think about it, the photons have to build up. So you're going to start to see a max dose, like 1 to 2 cm down in here. And so what that means is if you say you just had an AP beam here, you would have a dose max around here, but only like 30 to 50% at the surface. So the way the optimizer fixes that is it puts in a lot of modulation coming tangent to the surface and just pumps in dose. So it comes in laterally, and again, it looks pretty good on paper, but what that doesn't do very well is transfer to a patient, because a patient's not going to be in the exact same spot. And so I went through a lot of different scenarios of different PTV expansions and shifts, but so again, this is a 2 millimeter, so it's saying the skin's about 2 millimeters, optimized a PTV to it. And then I moved the beams 1 millimeter and recalculated the plan. And you end up getting about 20% of the PTV is now going much higher. So here's the 2 DVHs. So you can imagine if you were trying to optimize to the skin, that ends up being closer to 50% when you get close to the surface. So again, it's having to put a lot of dose tangential to this target, which you don't see at all in here unless you go through and look at the segments. So this is just something to think. If you're wanting to treat the skin, you really need to use bolus. On paper, it might look fine, but in reality, you have a very high likelihood of delivering a lot of dose to a patient if they move any. And if you ever want to test this and see if your plan is optimizing and like pushing too much dose sort of laterally or tangentially to the surface, in Eclipse they have that uncertainty tool, or the position uncertainty tool. Sorry if I'm saying the name of that wrong, where you can calculate the plan with a bunch of different shifts, and you can actually see that when you do this. So if you're ever worried about treating the skin inverse planned, you can use that tool and see like how realistic is that. Because you can imagine if this was a prostate and you move it a millimeter, you're not really going to see much of a difference. I mean, so that's kind of the idea there. So use bolus, very important, or subtract about 5 millimeters from the skin. Other optimization structures, this is just kind of a quick aside. Rings, you might not need them if you're using NTO, but you also might. Head and necks, like they're very different, and so sometimes you need things like that, sometimes you don't. I've been using manual NTO more on things, and I found I don't need rings as much as I do if I'm using automatic. I'm not sure if that applies the same for everyone, but that's just kind of what I do. For a posterior void structure, that's just kind of like a big wedge or triangle that goes, sort of includes the cord, goes back to the posterior skin, counts for lymphatic drainage, and it's just a great structure to keep dose from entering through the cord when you're going posterior. Some physicians really like the hot spots right in the middle of the GTV, and one way our dosimetrists do that is they make sort of a limiting structure on their PTVs. So, I mean, the name here doesn't actually matter, but it's effectively, it looks like a ring, like an inner ring on the PTV70. So if you take the PTV70 and you subtract your GTV or CTV from it, and you try to keep that cooler, than the actual GTV or CTV, it kind of forces a hotspot to be inside the middle. So if you have a physician that loves the hotspot right in the middle of the high-dose PTV, that's one way to do it. And again, if these aren't making sense, please send in questions, and I'll try to cover things a little more in the end. Split fields, that's something I get a lot of questions on, and we've adopted it in our clinic, and our dosimetrists do a great job with it. So what we do here is if you have a patient with long node chains, we split the fields like this over here on the right. So typically we do 4 fields with the collimator rotated 90 for these two. So you can imagine the MLCs going, soup and imp here. And then we have 2 fields with the collimator at approximately 0, a few degrees kicked off. And if you sort of look at this, you can see that the MLCs are going to be able to close in and actually not expose the middle. Sorry, I thought I had the laser pointer on. So for these fields, the MLCs will be able to close in, and when you fix the jaw like this, the jaw's not going to open up. So I'm not sure if people are aware that if you are going to optimize something in Eclipse, if you type in jaw coordinates before you go into optimization, the optimizer will not open the jaws further than that. And so when I say we optimize stuff with fixed fields like this, the jaws will still be able to close, but what we're doing is we're setting sort of an upper limit. So we wouldn't want this X jaw to open all the way down here. And I think the biggest benefit of this is that you're not going to have open segments between the 2 node chains. And that kind of helps, especially on head and necks, when you have things like the larynx, esophagus, cord, all those things in the middle here. It really helps spare those structures, and it helps the optimizer because you're not having to make as many decisions. I mean, the jaw is doing some of the blocking for you, so the optimizer is focusing on the PTV more. And I've heard from some people that they're worried about integral dose with this or just the excessive monitor units, but I would challenge them to actually try this technique. You don't see much more monitor units. Typically, these are about 150 MU a field. And honestly, what I've seen is the integral dose is lower to these patients because you're not having open segments, just treating tissue that doesn't need to be treated. If you want to actually go in and look at your integral dose, if you turn on your body contour and just the volume of the body contour times the mean dose will sort of give you your integral dose. So if that's a concern in your clinic, you could try those 2 scenarios and sort of, see if you feel comfortable with it, because it's something we use in our clinic. It works fairly well. It adds about 2 to 3 minutes of treatment time. So if you do have a patient that cannot lay still, then maybe you can't do it. Maybe you do 3 fields. Maybe you do 2 fields. Maybe you medicate the patient. That would kind of be a physician decision. But for most patients, we are by default doing these 4 fields, and we find that the plan quality does seem to be markedly better. And then when we actually get into optimization, RapidPlan, just one word, is a great starting point. This is probably my favorite feature of it is the estimate DVH that it can come up with. So if you haven't used RapidPlan before, you can build a model from multiple plans, and RapidPlan is going to sort of make an estimation of where doses should fall on these structures. I'm probably not doing a great job explaining that, but there's tons of marketing material on what RapidPlan does. But I love using it for this estimate DVH feature. It's extremely useful when you're trying to figure out what you can spare and what's a reasonable dose, or if a physician wants you to spare something, and you can sort of point to this and say, statistically speaking, we shouldn't really be able to do that unless we're going to compromise target coverage. And so RapidPlan will give you a very quick idea of where doses need to be. And sometimes it's great because if something can be spared more than you would try to, so say like a parotid, you put your mean dose in the low 20s, but it could actually be down to 10 or 15, RapidPlan will kind of point you in that direction. So it helps you know if something can be spared, and it also makes sure you're optimizing all the structures you need to, because you have to assign each structure to a contour, and then also, if you can spare something, you might as well spare it. So that's sort of my fun RapidPlan part. And then in optimization, again, I'm sort of assuming that people have done planning in Eclipse and are familiar with the different nomenclature. So hopefully these words I'm using are making sense. But the normal tissue objective is one of the features in Eclipse. And you get a lot of questions on this of just like what values to use. And the main thing I would say is there isn't a single solution. A lot of values that you type in here can do the same thing. The main thing is to look at that little graph on the right, and that's going to show you what you want or what you are telling the optimizer to make the dose fall off look like. So when you go to the normal tissue objectives, you can use automatic, and that's a little bit of a black box to me. It's just you say automatic and you apply priority and it tries to spare dose. If you go into manual, you can set some parameters here. And so just to give a quick explanation of these parameters, the distance from the target border is exactly that. It's going to be the distance from your PTV that you want it to start looking at dose. So if you make it a centimeter away, it's not going to look at anything until it's a centimeter from the edge of your contours. And then the start and end dose is somewhat self-explanatory. It's the dose that it's going to try to keep either the dose, well, so the start dose is going to be what it wants the dose to start falling off from. So if you say 100% to 20%, it's going to look and say, at whatever distance I am from the target, I need to get the dose down to 100%. And then the end dose, it's going to try to keep it down to that level. But there's a little bit of a distance feature there that comes from the fall-off. And the fall-off is effectively the slope of that line. The fall-off can be anywhere from 0 to 10, where 10 is basically straight up and down, which would be ideal, but we never can actually do. And I'm going to show a couple more pictures of different things that you can do with NTO. But in general, you have a lot of different options here, and different values can do the same thing, which is kind of an interesting feature. But just remember, look at the graph if you're worried. So a couple other little pictures here. Again, a perfect slope would be 10, so effectively a step function, which, I mean, you can actually put this in and try optimizing it, and the optimizer applies a pretty big cost to this. So it tries to make the dose fall off fast, but obviously it can't do that. So it'll focus on that more than other structures. And then here's just a couple other ones. This VMAT chest wall is one I used a couple weeks ago that I just thought was kind of interesting, and I hadn't done one like this before, so I threw it in here. So again, if you look at the graph, it'll kind of explain what the values are I typed in here. So for a centimeter away, I said start dose 70, end dose 20, because I wanted to allow the 100% dose to spill outside of the PTV sum. So what that does is, if you can imagine like a chest wall or a breast where you're normally going to have tangent beams, you would treat more than the breast sometimes, and you're going to have that dose spill out to the side. And so this would allow that without squeezing the dose too tight on the side, where if you allow it to come in from the side, you can sort of spare the lungs a lot more. And again, but different values you to type in can do this. So this isn't, I'm not saying use this on all VMAT chest walls. It's just an example. And again, SBRT, you just want a very quick dose fall off, and this is sort of just to show a way to look at this graph over here. So you have distance, dose percentage. For a lot of long SBRT, you want the dose fall off to be around 50% at 2 cm. It kind of makes it look like a conformal plan. And so if you have the line here sort of mimicking that, I mean, this would be effectively 2 cm away. Sorry, I thought I had the laser pointer on. So you're effectively 2 cm away, you're below 50%. Like this would be a great dose to see on an SBRT plan. So if you have this NTO and then a PTV and an ITV constraint, you could probably get a pretty good plan in, you know, like 5 to 10 minutes. So the NTO is a great tool to help you get plans done kind of quickly. And I just encourage you to try different numbers, try to make sense of what you're typing in, and make sure that the slope of that line goes along with what you're actually trying to do clinically. And some other optimization strategies, pausing the optimizer while you adjust different things or just let it optimize out. That was something that I found to be very important when Eclipse was in version 11 or if you were using the PRO. But I find it less important with the photon optimizer that started in version 13. I still do it when I'm adjusting different constraints, but I don't necessarily pause the optimizer and just let it run for 30 minutes like I used to. And also, in the PO, the resolution is a feature that was different than the PRO. So if you remember in version 11 or before, you could go in and type in different resolutions for structures. But in the PO, what you do here is you can just kind of select a resolution during the optimization. So for head and neck plans like a nasopharynx, for instance, if your target's up near the brainstem, the optic apparatus, you might do an initial run at 2.5 millimeter resolution and then go back in and continue optimizing it at a 1.25 millimeter resolution. And it really looks closely at those small structures when you do this, and it does take longer as well. It's effectively a factor of 4 more voxels to keep track of. And so you can change this after an optimization and not have to recalc. And some other things to try. Mean dose on optimization structures is something I think people are in general fairly familiar with. Like if you had a parotid and you subtracted the PTV out of it, you could put a mean dose on that optimization structure, but you still evaluate normal structures. It's just kind of a useful tool to prevent targets from losing coverage. One thing I really like to do is set priorities of 1,000, which I know makes a lot of people at Varian cringe and have lots of different colorful conversations about it, but I think it works extremely well. And so I'd say give it a try, and I use this in some scenarios where, say you had a very specific dose you needed to achieve, and you've already achieved it, and you want to start working on other things. So say a cord dose, you had it at 35 gray, and you were great there, but you wanted to work on other constraints and normal tissues, and you didn't want to worry about the cord anymore. So I'd say put an upper of like 4,000 on the cord and set a priority of 1,000. And what that does is if the dose ever starts getting close to that, it'll just prevent it from going over for the most part. So it's kind of like a great placeholder. Or if you have a parotid mean dose and you're happy with what it is, say you want to keep it below 20 gray and you have it there, you could put a mean constraint at 20 gray, set a priority of 1,000, and then just kind of leave it alone. I mean, you still need to evaluate it, of course, things can happen, but it's a great way to hold doses and even for coverage. So if one of your PTVs is covered, let's say you have it at 98% coverage, but you only need 95. You could set a lower constraint at 95 with a priority of 1,000, and then start going through and adjusting your normal tissues and try to see, how much you can actually spare those structures. And it'll hold your PTV coverage in place as long as you don't put in a priority of 1,000 on every target. So, also doing another intermediate dose calculation. If you are calculating something that's like kind of near a sinus or air cavity, when it's optimizing and then it goes in and does a dose calc, sometimes you'll see your DVH just does not look like what it looked like before. And I found that the more intermediate dose calcs you do, you actually get better agreement. And so, this is sort of the extreme cases if you're doing a lung structure. When you go from intermediate dose calc back into the optimizer, you'll see just a very big discrepancy. Your targets aren't covered anymore. And this does happen in head and neck too when structures are sort of in air or sinus, like around the nasopharynx, just anything up there. And so additional dose calculations help get you closer to what you're optimizing. So I hope that made sense. And then the dose to contour tool for additional optimization, that's just after you run a plan, you can turn dose levels into actual structures and then use that in your optimization if you're just trying to get hotspots down or you have one specific area that you need to control. And then just to make sure we understand the cost function tool, just a brief explanation here. When you're optimizing and you're adjusting priorities, the goal is when you raise a priority that you're increasing the cost. Because if you're raising a priority, that means you want the optimizer to focus on this more. And a way to visualize that in version 13 is to just scroll over your actual constraints that show up on your DVH, and you'll see a percentage. And so that percentage, so this one right here says 5%. So effectively, the optimizer is working 5% of its optimization resources on this constraint. If we look at over here, you can see that the body is the main cost function here. I'm not exactly sure why. This is, again, just a screenshot for explanation, but it helps you know when you're optimizing something, if nothing's changing, why. And so if you have a cost or a priority of 50 and you make it 100, you might not notice it move here at all. But if you were using like a mean dose, sometimes mean doses, the cost function increases much more rapidly than an upper or lower constraint. But so this is just something to be mindful of when you're adjusting priorities. It's always a good idea to look at the cost of the priority that you're adjusting to make sure that you're moving the number you're typing in there a meaningful amount. You don't want to just sort of type in a random thing and hope it works. You want to make sure that when you increase it, the optimizer is actually going to do something about what you're doing. And a high cost does not necessarily mean that that's bad. Like if the plan is doing what you want it to do and the cost function to that one structure is high, I mean, that's okay. You just need to make sure that what's happening in the plan is what you're wanting. One thing that comes up a lot is, do you spare a structure or cover a target? And I mean, this is something that's definitely a physician call. And if you don't have clear guidance from the physician, one thing that's really good to do is to make a plan doing both. So you give them 2 plans to choose from, which isn't always ideal, but it's a great way, especially for you to know sort of what the 2 extremes are. Because head and neck planning isn't as straightforward as some of the other plans where you're going to go through it once, a physician's going to look at it and approve it. That might happen for head and neck, but there's a lot of times where you're going to come in and have to re-optimize something because, again, they weren't aware of the doses at the time. And so some things you can start to do is you can subtract, if the idea is for, like this case, to spare a parotid. You want to make sure the CTV is still covered, but you can subtract it out of the PTV. Like that's kind of a thing you might hear from a physician, and that's okay. Or they might say, spare the parotid altogether. But again, there's a lot of different ways physicians can deal with this. And I mean, even if you're at one place and there's multiple physicians, they might all have different ideas around this. But I think the most important thing here is to, if you are going to give them a scenario, just make sure it's the best scenario for what you're giving them. So when patients are under treatment for head and neck, a lot of times they lose weight. That's a very common thing that happens. Dosimetry in physics gets called. Physician wants to know what to do. And so I was trying to come up with a rule of thumb because this is like a random, or not random, it's a very common thing that we have to go look at. And so I was trying to like actually write out my way of thinking here. And so if you were looking at TMR for a 6MV beam, it changes by about 3.5% for a 1 cm change in depth. So you can kind of think of that as thickness. And so that would be for like a clinically relevant depth and field size. So it's from a depth of like 9 to 10 cm for a 10 or 15 cm field. And that would be a uniform change. So say you had a sphere, that would be the sphere contracting 1 centimeter. But weight loss is rarely uniform. Like if you're looking at a patient, you might see like, oh, laterally they're a little smaller, but from the AP and PA it seems okay. And especially the PA portion of an arc, I mean, that's normally the patient's back. Sometimes they lose some weight in their shoulders, but it's rarely a uniform circle. And so when I was trying to think of a good way to explain this, I wrote up a little problem here. All right, so here's my weight loss problem. Dosimetry in physics is called to look at a cone beam CT for a patient who has lost weight. The patient has received 25 of 35 fractions. The PTVs appear in the same general area, but there is a noticeable difference in the body contour. Do you reef them? And so just for this specific case, I said, well, about half the arc is a 5 millimeter change. So let's say the sides, so like the sides of the neck are about 5 millimeters, and then the anterior portion has shrunk by about 1 cm in tissue. And again, these are like just ballpark, rule of thumb, like off the cuff calculations. So if half of the arcs are going through an area with a 5 millimeter change, that would be about a 2% increase in dose. And then about 25% of the beam, so that's the anterior portion, is going to have a 4% increase in dose. And so that would be a roughly 2% increase in dose to the patient for that treatment. But that doesn't mean the patient has been like this since day one. So one thing that's important to do is to try to determine where this change has happened and if the change is, and to monitor like, is this change increasing? And so if you're doing the split field technique, it's very useful because when you're looking at weight loss, you're thinking about max doses to things. And the cord is pretty much going to be shielded, and the cord is normally in the similar spot. So the cord's not going to really be increasing by that much. But one of the things you will see is that the PTVs could get a little bit hotter. And one of the really important things is if normal structures start to move. So like if a patient lost weight in their shoulders, you know, their PTVs might have moved posterior, and so now they're, like the lower nodes are now out of the initial contours. And so that would be a time when you would definitely need to resim. But if things are like pretty much falling in the same spot, they've just shrunk, you might not need to. So like if this was the case, it would be one of those things where you could probably say it's fine to treat that day, we'll look at it more. And one of the ways we look at it more is you can use a cone beam CT to define a new body contour and recalc on that. And so when a physician asks us to do this, we go into Eclipse and we have the cone beam CT fused to the treatment planning CT. We modify the body contour to be the same, to have the same outer measurement as the cone beam CT. So if you're familiar with the contouring features, you can do a Boolean operator and clip the cone beam CT and have that set as the outer contour for that region. Make sure the beams are at the same isocenter, and then recalc using the preset values. So this button right here, Shift F5. So what that's going to do is take your new body contour, which I know is not the exact same thing as a new CT. I mean, there are things that move inside of there, but in general, the spine is in a similar spot, and soft tissue isn't that different, so we kind of assume that this is going to give you a decent calculation. So cord dose might be higher, but you know, you want to look and see, did normal tissues move, and are they now in the high dose region? And then is the tumor outside of the PTV? So there's just some like really important things you want to look at when you're redoing this. And also at that point, a physician might say that they want to re-CT because they're just not sure. And when you re-CT a patient, it doesn't mean you're replanning the whole patient. It just might be a more accurate way for you to calculate the current plan onto it and evaluate. But weight loss is a real thing that happens in these patients, and it does need to be evaluated on a large majority of them, especially around like fraction 25. Retreatment is something we don't see that often, but when you do see, you kind of scratch your head and say, what do I do? Because now you're looking at doses going over 100 gray. You start to wonder what that means. And I think one of the most important things is this is another one of those things where you want to review the previous plan and prognosis with the physician. Kind of go over the complication and toxicity risk and try to figure out when toxicities could happen and what those would be. It's important to determine if this is a new primary or a recurrence, because recurrences can sometimes be a little more radio-resistant. So in general, these aren't great scenarios. But when you get around 100 gray, there's different structures you need to take into account too. So carotid blowout is a real thing. When you get around 90, 100 gray or higher, that can happen in about 2 to 4% of patients. And so that's just one of those risks that you want to make sure you review with the physician. And the spine brainstem has normally already been taken pretty close to tolerance from an initial treatment, but these do recover. We don't have a lot of great information on what happens in adults with this, but MD Anderson has they published about monkeys that they reirradiated, where after about 3 years they showed full recovery. Around 2 years, I think it was 80-ish%. St. Jude has published on reirradiating pediatric patients, showing that brainstems recover as well. And so like these things do recover, but we don't have great data on what happens in adults when we retreat a year or two later. So this is where going over prognosis with physician versus risk from the dose that you're going to deliver is very important. And then also osteonecrosis. So when you think of the mandible, I mean, this can happen from a single definitive treatment, taking your PTV up there to about 70 gray. You can get necrosis in the mandible, and so keeping track of bone doses in these is very important as well, because those are things that typically end up requiring surgery. And there aren't a lot of great guidelines on what to do for these, but the ACR does have something called the appropriateness criteria retreatment of recurrent head and neck cancer after prior definitive radiation. And I really like this because it gives you kind of a good decision tree that you can go through and talks through different scenarios, different specific types of head and neck cancers and what you should look at. And it does have some references to different studies where people have published on reirradiation. So I'd say that's kind of one of the worst case scenarios you get when you're planning head and necks is when you have to retreat. And you really have to rely a lot on your physician expertise and with that, and just really have an open communication and go over that. So here's some takeaways, or hopefully the takeaways that some of y'all got from this talk is that there is a wide range of treatment techniques. By no means am I saying that these are great standalone and you must do these from now on, but there's a lot of different ways to do it. And I think one thing is to really make sure that to question yourself and make sure what you're doing makes sense to you. Then find some way to motivate you to learn, to make sure that you're trying to constantly improve. And at least for me, I found working with students is a great way to do this. And people that are newer in the field, they always seem to know something that you don't. And probably everyone you work with knows something that you don't. And so it's really important to communicate with each other, share ideas, argue with each other, not be afraid to question each other. And then one other thing is to participate in plan studies. So Varian has done them. Prono is doing one in a couple weeks. That's actually a head and neck case as well. And I'm looking forward to doing that one and probably going to mostly use the things I said in this talk today. So that's about it. So thank you, everyone, for listening, and the people I work with for always being open to arguing with me, and for the people at Varian for putting this on.
Thanks, Jonathan, for a great presentation.